Hands-on Mechanical Ventilation by Dr. Gerhard Wolf and Brian Walsh.
My name is Dr. Gerhard Wolf. I'm a pediatric intensivist at Children's Hospital Boston, and this is Brian Walsh, one of our respiratory therapists. And we will demonstrate you how to set up the ventilator for a child with a pneumonia.
Initial ventilator setup.
This is a 3-year-old child that just came in our ED. The weight is 10 kilos, and the baby has a community-acquired pneumonia, and we actually intubated him because he was in respiratory failure. And I was wondering, Brian, if you could help me set up the ventilator and take us through what your initial settings are. I'll take over to bag.
Come on back in. So we'll come over to the ventilator, and we'll have a ventilator that's been fully calibrated and checked out. In our unit, we typically will start someone off in SIMV with volume control. We'll set the tidal volume at 8 cc's per kilo, which is 80 mLs for this particular child. A rate of 20 because we're trying to mimic basically what Dr. Wolf is bagging at. A PEEP of 5, 100% oxygen, once again because we're on 100% oxygen. The inspiratory time is going to be set at 0.65 because that's just kind of physiologic for this particular patient. Pause time is set at 0. The inspiratory rise, or how fast we'll deliver the breath, is at 0.1. Flow triggers set pretty standard at 0.5. Inspiratory cycle time off, once again, is pretty standard at 20%, as well as the pressure support of 15. The child is not spontaneously breathing right now, so we'll have to assess those at a later time. We'll hit accept. We'll actually put the patient on now.
Ready? So we'll disconnect him from the bag, and we'll put him on the ventilator.
So we'll go back to the ventilator and we'll check to make sure that we're actually pressurizing the circuit and the patient. We'll look for chest rise and fall, and we'll ensure that everything is working appropriately. You can see that our peak pressure is a little bit on the high side, but anything below 30 we tend to be happy with. Our mean airway pressure is 9, our PEEP is 5, our respiratory rate is 21, our FiO2 is 98%, and our minute ventilation is 1.5. Because the tidal volume of inspiratory and expiratory tidal volumes are roughly at 80, which shows that we don't have much of a leak.
Point of clarification. A leak around the endotracheal tube can be caused by either an endotracheal tube that is too small for the patient, using an uncuffed tube with high ventilator pressures, not inflating the endotracheal tube cuff, or pilot balloon adequately, or more rarely, a pneumothorax. You can detect this leak on the ventilator by looking at inspired versus exhaled tidal volumes. If there is a large difference between the two volumes and the exhaled tidal volume is much less than the inspired tidal volume, then a leak is present.
So let's look at the vital signs. The heart rate of this baby is 117 at the moment, with a blood pressure of 96/69. Over the arterial line that we just placed, the respiratory rate is 26, and there is an entitled CO2 waveform, and there is a number and a waveform, which is a waveform over time. So the entitled CO2 is at the moment 44, and there's also a nice square waveform, which is sort of reassuring at this point. So the SAT is 99%. Do you think we can wean it a little bit?
Yeah, so I would wean probably in 10% increments, and so we'll go to 90% right now, and we'll try to target a saturation just greater than 92 at this particular moment in time.
Why are you worried about giving the baby 100% oxygen at this point? I mean, we started with 100% on the bag, and the initial setting was 100% as well. Are you worried about oxygen toxicity at this point?
Absolutely. That's the thing that we try to avoid, and so we feel comfortable if we can get the child below 60%. If we're above 60%, then we would likely make some manipulations in the ventilator to try to improve FRC.
So I suggest we give it a couple of minutes, and then we'll come back to the ventilator settings.
Recruitment phase.
I've had the chance to get a chest x-ray, which you're looking at the moment. On this chest x-ray, we can see that there is bilateral opacities over the lung fields. The lung volumes look low. The endotracheal tube is in the right position, and the heart size looks normal to me. So let's take a look at the baby. A couple of things have changed. The baby seems to be a little sicker as we assumed in the beginning. Just looking at the baby's perfusion, the baby's slightly cool, the pulses are weak, the baby is a little more tachycardic than before. I listened to the lungs again. There's crackles on both sides, and the air entry is kind of diminished. Also, there's less of a chest rise than there was before. Let's just take a look at the vital signs. The heart rate is 130 now. The baby's a little more tachycardic. I think the baby might get a little septic. The blood pressure is still okay, 90/60, with the mean arterial blood pressure of being 70. So I think we have a compensated situation here. The blood pressure is still normal, but the baby is tachycardic, so it's probably compensated shock at the moment. Also, the SATs went down. They're only 86 at the moment. We still have an entitled CO2, but it's gone up a little bit from the low 40s to the higher 40s. So, Brian, what can we do on the ventilator to make this baby better?
So another thing is we're now getting a high peak pressure alarm in volume control ventilation, which is showing that our compliance is worsening. So I'd like to recommend that we go to pressure control ventilation and choose a little bit more lung protective strategies of 6 cc's per kilo tidal volumes, as we are at 8 right now.
So in summary, you have the same volumes still programmed because we were in volume control, but to achieve those volumes you had to use higher and higher pressures were chosen by the ventilator.
So now we've switched over to pressure control ventilation. We adjusted the pressure for 20/5 or 25/5.
Point of clarification. The peak inspiratory pressure, or P-peak, as it appears on many ventilators, is equal to the sum of the set inspiratory pressure and the PEEP on the ventilator. If one wishes to obtain the delta pressure, simply subtract the PEEP from the peak inspiratory pressure.
Now our tidal volumes are, we're trying to shoot for 60 cc's, which would be 6 per kilo. So I'm going to adjust the peak inspiratory pressure up just a little bit more to try to achieve that. And so I think we've gotten transition to pressure control appropriately, but I'm still concerned about the saturations of 85 to 86% on 100%.
So the SATs are low, are in the mid-80s on 100% oxygen. How are we going to fix that?
So I would suggest that we go up on the PEEP, and so we can go up by increments of 2 to see if we can actually get the saturations to improve. Now, this might not immediately happen. It might take a little bit of time to actually re-recruit the lung, because when we actually go up on the PEEP, we're actually taking the plateau pressure up as well, and hopefully that'll open the lung a little bit.
So you're going up with the PEEP to recruit more lung volume, to have atelectasis opening up, and to hopefully have more lung units participate in gas exchange than are right now.
Point of clarification.
Now, I'm going to show you an actual pressure volume curve generated by an isolated set of sheep lungs. So here we are at 0 centimeters inflating pressure, and this represents the isolated lung preparation. And you'll note that there's not much aerated lung. This does not look like a healthy gas exchanging organ. Now we're going to slowly increase the airway pressure to 4 centimeters, 8 centimeters, and notice at the bottom of this slide are the corresponding pressure volume points generated by this pressure volume maneuver. Now it's not until we get to 12 centimeters of water that the lung begins to open and we see healthy gas exchanging regions of lung appear. And here's a lung at 16 centimeters of water. The lung now looks open and it looks like a healthy lung. This is total lung capacity defined in this experiment as 20 centimeters of water. Now importantly, watch what happens to the lung as we march down the deflation limb of the pressure volume curve. This is 16 centimeters of water, 12 centimeters of water, 8 centimeters of water, 4 centimeters of water. So once we recruit the lung, we can significantly decrease distending pressure and not experience alveolar collapse.
So we're on 7 of PEEP and still on 100%. The SAT really hasn't gone up any. Do you think we should go up again?
Yep, I think we should. Maybe we can just go to 10 right now and see if we can actually improve those saturations.
So at this point we're titrating the PEEP essentially to improve oxygenation. So we've gone up from 5 to 7 to 10 of PEEP with the hope that the baby will have better SATs, and we're still on 100% oxygen. So since you set the delta on this ventilator, the peak inspiratory pressure also went up, right?
Correct.
So what are we on right now?
So this is 30/10.
And did the volumes change at all?
So the volumes actually got a little bit better. They're about 64 or so, and we might be able to lower our peak inspiratory pressure as well with that to try to keep it around 60 cc's.
So at this point, we kept the delta the same. So how do you explain that the tidal volumes actually went up when the delta P is actually the same?
So hopefully we're recruiting lung as we go through those. So we're improving FRC and keeping the lung from getting atelectatic. And so it allows us to ventilate with less pressure.
So we may actually go to, hopefully, to a more beneficial part of the pressure volume curve here by using more PEEP.
One of the other things I would also recommend that we lower our threshold so that we can try to lower our FiO2 as well to achieve SATs of 88 to 92.
Point of clarification.
Please note, there are a couple of reasons why you may want to change the oxygen saturation range to 88 to 92 in patients who require greater than 60% oxygen and have evolving acute respiratory distress syndrome. This is done to lower the risk of oxygen toxicity and lower ventilator pressure such as positive end expiratory pressure. This simple change will lower the oxygen content but maintain the content within normal limits if your hemoglobin level is normal. Choosing a lower oxygen saturation target allows for optimization of the ventilator with the least associated injury. Certainly, contraindications to lowering your saturation ranges would be anemia and pulmonary hypertension in which oxygen is being utilized as a vasodilator.
Stabilization phase.
All right, so we're back at the bedside. We were able to grab an arterial blood gas from the art line, and the blood gas is, the pH is 730, the PaCO2 is 53, and the PaO2 is 59, which probably matches our SAT because the SAT is 90, and we expect the PaO2 to be around 60. So, Brian, are you happy with that gas, or do you think we have to?
No, unfortunately, we're still on 100%, and so I think that there's some more lung recruitment that we probably need to do. So I would recommend that we go up on the PEEP again.
Okay, that sounds like a good idea, with the hope that we can wean the FiO2 from 100% at some point. So in general, what blood gases are we aiming for here? This isn't a bad gas if it wasn't on 100%. I mean, at some point we would sort of accept some acidosis. I think as long as the pH is 7 to 5 or higher, we would accept some higher CO2s, and we'd hope for PaO2s in the 60s, which would be a SAT around 90, which is sort of the permissive hypercapnia and permissive hypoxia strategy. And explain to us why that is lung protective.
Well, it allows us to actually choose those 6 cc's per kilo tidal volumes because ultimately it's our minute ventilation that a lot of times helps with CO2 removal. And so when we have 6 cc's per kilo tidal volumes, occasionally you'll have to go up on the rate to actually help compensate for that or accept a higher CO2, such as CO2s in the 50s and even low 60s.
So we just went up to 12 on the PEEP and we're still on 100%. Do you think we should go up once again and get a blood gas?
Yeah, let's go on up to 15.
Plateau phase.
So after the last vent change, we were actually able to get a blood gas, and things have improved a little bit here. The baby's SAT has gone up to 100%, and the last blood gas was a pH of 732, and the CO2 is 53, and the PaO2 has improved from 59 to 110. So I think with the last maneuver that we increased the PEEP, we actually probably achieved some lung recruitment. And do you think it's time to wean a little bit?
Absolutely. I think we should probably go to 90% on the oxygen and just monitor our SATs and continue to go down in 10% increments every 10 to 15 minutes as long as our SATs are 88 to 92.
So we'll actually continue to wean the FiO2 at this point, leave the PEEP where it is with the hope to get closer to 60%?
Correct.
And what else happened?
The other thing is I'm still concerned about is our peak inspiratory pressure is still 37, and it's above that 30 to 35 range that we like to avoid. And so one of the things that I would recommend is that we go down to 5 per kilo on our tidal volumes to help accomplish that.
And how would you do that?
So we could go down on our delta pressure to 18 to actually lower our tidal volumes to roughly 50 cc's. But because I'm a little bit concerned about we're on the borderline of our permissive hypercapnia and our CO2s are in the 50s, I would probably go up on the rate to help compensate for that lower tidal volume. and so we'll go up to the rate of 22 or so, and watch our end-tidal CO2s as they likely will climb a little bit.
So in summary, as we've increased the PEEP to improve oxygenation in this baby, we've also increased the peak inspiratory pressure since our delta P has stayed the same at 20. And we've gotten to a range above 35 where we were slightly uncomfortable with the high plateau pressures. So we decreased the delta a little bit, and that brought our tidal volumes down. And we're now accepting 5 per kilo. But that also brought our peak inspiratory pressure down from 37 to 35. And in order to make up a little bit for that minute ventilation and not let the baby get too acidotic, we actually increased the rate as we decreased the tidal volume before in order to have the baby ventilate a little better.
Weaning phase.
So let's take a look at the ventilator. We've been able to make some weans, and let's see what happened.
So it looks like we're on 60% now with sats of 96 or so. And so it looks like we have a little bit of opportunity to wean some more.
So what would we wean at this point?
I guess we would consider whether we should wean the PEEP or not at this particular standpoint.
So like at this point you have achieved adequate oxygenation, probably adequate lung recruitment because you were able to wean the FiO2 from 100 to 60%, and your sats are 95, we could get a gas, but it's probably time to wean the PEEP a little bit, especially in the setting of high plateau pressures, I agree.
Great. So we can turn down the PEEP.
So we just wean the PEEP a touch, so we're on 60% oxygen, a PEEP of 14, a delta of 20, which gives us a peak pressure of 34, and we're at a rate of 22. And we're on a pretty high mean airway pressure. What is the mean at this point?
It's 19.
So the mean, again, is determined by the mean is the pressure area under the pressure waveform, so it's determined by the peak pressure, by the PEEP, but also by the inspiratory time. And so given that we have a peak pressure of 34 and a PEEP of 14, it's not surprising that the mean airway pressure is 19 at this point. And I think much of that mean airway pressure is probably transmitted to the heart at this point and may actually decrease preload of this baby because some of that pressure is actually compressing the right atrium. Also, we have to keep in mind the baby has a pneumonia, has been a little septic in the first place. So we've given additional volume. We've given a 20 cc per kilo volume bolus because the heart rate had been up in order to stabilize the blood pressure. And I would have a low threshold to start the baby on an inotrope as well, such as dopamine at this point, because I think we have to think about supporting the heart at this point, given that we are on pretty high ventilator pressures, and especially the right ventricle may need some help here to pump some volume against this ventilator load. So we're 2 days into this by now. Some of the antibiotics have apparently kicked in. The baby is more stable, and also we've been able to make some progress on the ventilator. So Brian, what were we able to wean?
So it looks like we're down to 50% oxygen with sats of 93. Our PEEP is now down to 10 from an ultimate high of 15. Our respiratory rate has been stable at 22, and our pressure control is down to 17 from 18, which gives us a peak inspiratory pressure of 27, and once again below that threshold of 30 that we kind of like to keep it below. Those pressures are actually giving us tidal volumes of 6 per kilo, which is showing us that the lung compliance is actually improving quite a bit. It also looks like our end-tidal CO2 is down to 40 or so, and so we'll just keep watching that and continue to wean as the lung compliance improves.
So a couple of things happened here. The baby's oxygenation got better. We probably recruited the lung in the first place, and now we need lower pressures to keep the lung open. And we're settled here on a PEEP of 10 with 50% oxygen. What do you think, Brian? Should we encourage the baby to breathe spontaneously a little more? And
Absolutely.
use some of his own respiratory triggering?
Yep. We would like to get the child to breathe spontaneously as much as possible because we think that that'll be the best thing for him, and ultimately get him over to a pressure support type mode of ventilation.
So we're 5 days into this now. The baby has been on the ventilator for 5 days. Let's look at the chest x-ray from this morning. It is actually much improved. You can see the lung fields are clearing up. There's less opacification, and the lung volumes are a little better. Brian, how are we doing on the ventilator? What's happening?
It looks like we're doing pretty well. We're down to an FiO2 of 45%. Our PEEP is now 7. We've lowered the mandatory rates to 10, meaning that the child is breathing spontaneously quite a bit on his own. And then also the pressure control is at 17, giving us a peak pressure of 24. You can see that the child is breathing spontaneously between controlled breaths, and so that was a controlled breath, and this is now a spontaneous breath. And so it looks like the child is moving towards the extubation phase.
So what do you think? Are we ready to extubate this child pretty soon?
I think he's definitely ready for an extubation readiness test, and our criteria for extubation readiness test would be an FiO2 of less than 50%, which we are at 45, a PEEP less than 8, and the patient is spontaneously breathing. So I think it's worth a try to see if this child will actually pass an extubation readiness test.
Extubation readiness test.
Let's talk about the criteria for extubation a little bit. First of all, I think we want to ensure that the baby is still hemodynamically stable, which the baby is, has good perfusion and good blood pressures, is not an inotropes. We want to make sure that this is the case because we don't want to take the breathing tube out and then we have hypotension and we need to reintubate in that circumstance. Also, we want to make sure the baby is awake. So the baby should be somewhat moving, open the eyes occasionally, and be sort of breathing on the ventilator. Because one of the reasons why babies or children will fail extubation is that they are too sedated. So we want to make sure the baby's awake. Also, we want to test that there's a leak around the endotracheal tube. We do that by letting the cuff down and just taking we'll take a listen here to see if there's a leak. That sometimes helps us assess if there's still airway swelling in place, especially after the baby got a lot of volume. And then we'll look at the parameters on the ventilator, and I think we're on 45% oxygen here. We're on 10/7. The patient here has an endotracheal tube of 3.5, so we'll use a certain delta to overcome the resistance of the tube. So we're on 10/7 here, 45%. The baby seems to be awake, breathing spontaneously. We'll make sure that the baby's NPO hasn't had any feeds for about 6 to 8 hours, and then we'll check a blood gas, and the blood gas will tell us if the baby's ready. Another thing we look at frequently when we wean the children to minimal settings, one of the first indicators that they will fail is tachypnea. So we do want to make sure that the respiratory rate is still comfortably in the 20s. When we do drop the settings and the baby is not ready to be extubated, we sometimes see that the respiratory rate goes up to 30 or 40, which means probably that they don't get enough volume. They try to increase their rates to maintain the minute ventilation, and we'll probably need another day to fine-tune the settings until the baby is ready for extubation.
Endotracheal tube leak test.
We will demonstrate you how we test for a leak around the endotracheal tube. I have a syringe here. Brian is actually bagging the patient at the moment, so I will let the cuff down. I will deflate the cuff, and then Brian will test for a leak. So at the moment he's bagging the baby, and he's listening here around the airway, and what he's looking for if he has any evidence of air going out beside the endotracheal tube. And he has the bag in the hand, and he's looking at the manometer, and so the pressure at which he hears the air going by the endotracheal tube is the leak pressure. So what did he hear?
So he appears to have a leak at 20.
Which means you were inflating the child or the bag to a pressure of 20, and that's where you heard an air leak.
Correct.
We tested the baby for a leak, and we had a leak at around 20 centimeters of water. That means we're probably comfortable that there is enough room around the endotracheal tube, so if we take the tube out, there won't be a lot of swelling, and that wouldn't cause stridor or airway compromise. So if Brian had tested this child and he wouldn't have heard a leak at 40, this would be an indication that this tube is actually still fitting pretty tight, and we have to ask ourselves why that is. Sometimes a child is intubated with an endotracheal tube that is too large, in which case we would not expect a leak to occur. But if we think that the tube is sort of a right size, it is kind of curious if there's no leak at a high airway pressure. So we would look into reasons for that and may delay extubation for a day, potentially give steroids in order to have the swelling come down.
Extubation.
All right, so we've determined that this child is now ready for extubation. The child is awake enough, the feeds have been stopped, and the The baby is on low settings, and we're happy with the blood gas. So we've gathered here to extubate the child, actually, and we've assembled a little bit of equipment that we may need that we just would like to go over. So the baby is still on a ventilator, but Brian has a self-inflating bag here. We picked a mask that fits the face of this patient in case we have to bag mask ventilate. We have a syringe to deflate the cuff, and we have a suction catheter through which we can suction the endotracheal tube. Supplemental oxygen here. So, Brian, shall we go ahead?
Yep.
So we'll disconnect the child from the ventilator, and we'll manually ventilate him.
And pre-oxygenate.
So actually, I'll take one more listen. Yeah, we have excellent air entry. So let's go ahead and extubate.
Okay. Let's go ahead and suction out his tube.
You want to suction the tube first?
Yeah.
Okay. How many passes do we do?
Just make one and see what we
So
get.
we go down, see if we get stuff coming up.
We get very little.
And why do we do that?
Just to ensure that there's not anything down there that that he can't cough up when we extubate.
Okay, so the tube was paid and there's nothing down there.
We'll switch over to our Yankar, clean out his mouth.
All right. So
We
we're
attempt to suction his oropharynx and also try to suction above the cuff.
All right. What is next?
So now we'll take the syringe and deflate the cuff.
The cuff is deflated.
Then we'll take the tape. And because infants or children don't follow directions very well, we can't get them to actually cough this out. And so what we'll do is we'll give them a big breath, and then we'll actually pull it out.
All right. So the tube is out. We have some supplemental oxygen here, just in case we need it. We'll put the nasal cannula on this baby and fix it. So the baby's breathing comfortably, actually. I'll just take a listen. All right, sounds excellent. Still a few rhonchi, so I think the baby has to cough a little more. And so I think we've successfully extubated this child. We'll monitor him a little bit, but he should soon be ready to leave the ICU.
Yes, we'll look for retractions and nasal flaring and tachypnea as well.
So this concludes our session on mechanical ventilation. Thank you.
Please help us improve the content by providing us with some feedback.